The real goal is to minimize any hospital-acquired deconditioning or cognitive decline or something like that, right? We don't want to send a patient home with delirium if they didn't come in with delirium, right? Um, and so that's our main role is we're assessing their function and then ensuring that they're safe to discharge home, or if we're recommending continuing services like rehab or home health services or outpatient services.
Everyone in healthcare has a story that they never forget. Some are beautiful, some are difficult, most are never told. This is the space where folks in healthcare talk about the moments that changed them. Welcome to HuMed, where we talk about the emotional, moral, and human realities of medicine. I'm Dr. David Spiro. Thank you for being here. I'm incredibly delighted and honored to have Dr. Pooja Patel, who has lots of degrees, which I don't understand fully, but Doctor of OT, OTR/L, BCG, and CDP. I'm a physician. I don't know any of these terms, but we'll get into that. We'll get into that. She's a double board certified occupational therapist and gerontologist with nearly a decade of experience across acute care, long-term care, academia, and consulting, and a reputation for saying the quiet parts out loud when it comes to aging in America. And I love the longevity space, so this is going to be a fascinating discussion. She is the founder of Aging Together, an educational consultancy supporting family caregivers, and the host of Aging Together Unfiltered, a podcast amplifying the clinicians, innovators, and thought leaders reshaping how we think about growing old. Whether she's at the bedside, in the classroom, or behind the mic, Dr. Patel brings a rare blend of clinical rigor and lived-in honesty to one of the most urgent conversations our profession and our society needs to be having, and it's really taking care of folks that are aging. And uh, before we get into your story, it's really very meaningful to me. I'm a pediatrician, so what are we talking about here? But HuMed is about everything. Um, Societies are judged by how we take care of our most vulnerable populations. One of them is children, and the other is our elderly population. So I'm incredibly honored to have you on the show. Welcome, Pooja.
Thank you so much for having me here. And I have heard that, I believe it's an African proverb about you can tell a lot about a society and how it treats its most vulnerable, the children and the elders.
Yeah. So tell us about your story. What story would you like to share with us today? And then we can kind of get into the work that you do.
Yeah, I'd like to share a story that got me into the work that I do. And this story is about a family. It was a mother who came into the hospital with respiratory failure, probably a viral infection of some sort that led to respiratory failure. And she was in the ICU on the vent, on a ton of sedatives. So, she's intubated, sedated, and she's
Was she a
got
younger woman? Was she a young mom, or how old was
no,
she roughly?
she was fairly, I mean, she was probably in her 70s, I want to say
Okay.
60s or 70s. I can't remember exactly, but she was a little
Hmm.
older. She had
Hmm.
five adult children, grown
Hmm.
children who were married, had their kids, had families, so she was relatively older. Um, and these five kids were at the bedside, day in, day out, very supportive, very involved in the mom's care. Now, the story that sounds like such a beautiful story, right? We have the kids involved with the mother at the bedside. And it really was until it came time to make some really difficult decisions. So this mom was not doing well. And even with the vent and the sedatives, they had tried weaning her off the sedatives a few times and it wasn't going well. And her lungs just were not working. And they asked the family, the doctors had to ask the family, what are her wishes? Right? She was
Hmm.
on full code, but she didn't have an advance directive. And she didn't have a healthcare power of attorney. And so now this decision had to be made by all
So
five
wait a second.
children.
Can you just describe for the audience what is an advance directive and what you,
Yes,
you said healthcare attorney? Power of
yes, a
attorney.
healthcare proxy.
So
Yep.
POA. So can you talk a little bit about the difference between those two? Because I think they get confused.
Yeah, absolutely. So, healthcare power attorney, or also known as a healthcare proxy, is someone who can make medical decisions on your behalf if you're unable to do so. So, in this
Hmm.
case, the mother was sedated and on a vent, so she could not make decisions for herself. So, ideally, in an ideal world, she would have identified someone to be able to make those decisions for her. She did not have one, so she hadn't designated anybody to make those decisions for her. An advanced directive, or depending on what state you're in, it's a medical order for life-sustaining treatment or a physician's order for a life-sustaining treatment. It's basically your wishes in writing as far as what sorts of medical intervention you would want,
Hmm.
specific to being on the vent, um, getting CPR, getting intubated, all of these things. Some of those are the same thing, but basically your wishes on how you would like to be cared for from a medical standpoint. She didn't have that either. She didn't have any instruction as far as would she want to be on a feeding tube? Would she want to be on life support? How long would she want to be on life support? None of this was discussed. None of it was written down. And so depending on, and there was no spouse involved. So there was no, usually in most states, the surrogate decision maker ends up becoming the spouse in most cases, but there was no spouse involved. And so next of kin in this situation were the kids, and there were five of them. And the hardest part of this was that the five kids were not all on the same page, right? Some of the kids wanted to save mom's life, do everything possible if she had even a 1% chance of recovering. And the other kids wanted to see her not suffer. And they said, take her off. She's suffering. She wouldn't want to live like this. Let's take her off. And this was a weeks long process that went on with the hospital ethics team, with the social work team, palliative, hospice, physicians, therapy. I mean, it became such a long process to trying to figure out what the next plan of care was going to be for this woman. And in the meantime, I mean, the patient truly was suffering, right? She's on a vent, she's sedated, she's out of it. Every time they would try to wean her off, she would be miserable. Um, and the kids were starting to grow apart because of this, because they were fighting with each other and they couldn't figure out what they wanted to do. And ultimately, the mother passed, and the kids ended up with a very shattered relationship because of this process. And that really got me thinking as to why we
And
don't
and
have more
and
of
I'm
these
sorry,
conversations.
real quickly, is it because there were differences of opinion about whether the mom would want to stay alive or persisting with advanced care to keep her body alive? Is that what the issue was with the children?
I mean, I think the issue it was a mix of issues, right? There was the side of where no one knew what mom would have wanted, but they're all guessing what mom would have wanted, right?
Mm,
So based on their own relationship with their mom, they're guessing this is what mom would want. But they all differ because they all have different relationships with their mom, right?
mm,
And then the other part, I think, is self-serving. Who doesn't want their mom around, right? And so I think a lot of it's a mix of both, of like trying to figure out what would mom have wanted, and then also trying to battle that with, well, I want mom around, so we're going to try to get her to stay, right?
mm. These are really tough decisions, and in fact, this is not completely this story is not completely irrelevant to children. In other
Right.
words, children are in horrific situations where parents have to make impossible decisions about whether to keep a child alive or not, and it's always a balance between both thinking about what is the quality of life going to be after whatever event happened, if there is any? Uh, can the team the medical team wean the patient off of a ventilator? And it's just complicated. What is the neurologic status? Is there good brainwave activity that we can best predict what it would be like off a ventilator? Because when you're on a ventilator, you're sedated and usually not fully with it. So these are really, really hard decisions. So What you have a doctorate in occupational therapy. What is the role of an occupational therapist in this kind of scenario?
So in the hospital, our main role is function and independence and safety. And so our main role is in discharge planning, where we're working with patients who come into the hospital for a variety of needs, whether it's
Hmm.
elective surgeries, whether it's a heart attack, a stroke, general medical issues. I have spent most of my career in general medicine and oncology. And so those have been the patients that I've primarily have worked with. On the general medicine side, it's a lot of older adults who come in with falls, infections, right? Pneumonia, UTIs, altered mental status, kidney and liver issues, dialysis. So all of these things are sort of where I've spent the bulk of my career. And in that role, we're assessing their functional status, their cognitive status, and their home safety environment to ensure that they are able to safely continue living in the home independently,
Mm.
as they did, or as that they can leave the hospital functioning at the same level that they came into the hospital with. The real
Hmm.
goal is to minimize any hospital acquired deconditioning or cognitive decline or something like that, right? We don't want to send a patient home with delirium if they didn't come in with delirium, right? Um, and so that's our main role is we're assessing their function and then ensuring that they're safe to discharge home, or if we're recommending continuing services like rehab or home health services or outpatient services. So that's a bulk of it. And then because in the hospital we often have social workers and case managers, we don't have to do a bulk of the social like environment work or the community resources work. But that is an area that a lot of occupational therapists will practice in.
So this story is a really challenging one, and you just feel bad for the family. Why? What are the barriers to people getting the documents in order before they have an event to so this kind of situation doesn't happen? And is it just that people don't think about it? They're not informed? I
I think it's a
imagine you have to
lot
go
of
to a lawyer and get documents signed or go online and do a power of attorney with an online legal service. So what do you see as the barriers?
Yeah, there's a lot of barriers. I think first and foremost is that people are just unaware. People don't
Mm.
realize how much paperwork needs to be done related to our healthcare in general. And I would say the second most common reason I hear from people why they don't talk about this stuff is because as a culture, as a society, we don't like to talk about death. And it's the only sure thing in life, and yet people don't want to talk about it. And I think there's a lot of taboo around it, a lot of stigma around it in different cultures. Some cultures think it's bad luck to talk about it, right? And so I think a lot of it has to do with people's perspectives on death and dying and how they want to or don't want to talk about it. And a lot of this work requires having those difficult conversations around death and dying, and I'd add dignity, right? And that's where, you mentioned how it's not unsimilar to how it shows up in working with children. The difference here is that older adults have autonomy and they should be able to voice their opinions before something happens so that we can help maintain their autonomy even in death and dying, right? And so I think there's a lot of barriers there. And then, yeah, like you mentioned, I mean, it's all legal paperwork, right? So some documents go through your doctor, some documents require a notary, some documents you have to go through an elder law attorney. Some documents, if you really get into it, you go to an estate planning attorney. I mean, there's so much involved with planning for death and dying or planning for long-term care that sometimes it feels like there's too much and people just don't want to deal with it until they have to.
Yeah, it's interesting, right? And of course every everyone in the US and the world, they have also different beliefs about death, not
Hmm.
just in terms of how you die or where you want to be buried, but also beliefs about the afterlife.
Hmm.
And so uh, I didn't imagine we'd go there, but I do want to share with you a quick anecdote, if I can, about my own mom who passed away 3 years ago, almost to the day. And she had a really I had a really bad experience. My brother and I did. Fortunately, we were aligned, and we my brother was the proxy, but we were both aligned in what was going on. And my mom had a hemorrhagic stroke and was had a stroke a year or two before, and then started developing rapid onset dementia and was becoming less and less mobile, and then had a second event and was in the hospital super confused and not right and really nonverbal and not eating. And my brother and I were pretty clear what she would have wanted, which is to not eat and probably not stay alive in that state. Um, and where we ended up having conflict, and one of the many reasons why we had a difficult experience with the hospital. And it's interesting, I'm a physician, right? I should have some sort of medical terminology background and understanding. Adult hospitals are very, very different than children's
Hmm.
hospitals, very, very different beasts. But
Hmm.
um, the team really pressed my brother and I to for my mother to get a G tube, which is a gastrostomy tube. It's a tube you put into the stomach, for those of you that don't know, to feed someone, because my mother had an NG tube at the time that was giving her some nutrition. And my brother said, and I said, absolutely not. She's not going to be transitioned. I mean, she needs to pass away, because my mom would not want to be like that. And she was very, very clear about that to my brother and I when she was alive and well. And I think these end of life decisions are really charged. I think hospitals, uh, if you, I'm curious about your opinion about this, but hospitals are under pressure to move adult patients through. And when they get to a certain point, I get a sense that they really wanted my mom out into the next phase of wherever she was going to be, so rehab or nursing home kind of scenario. And that's not what um, my mother would have wanted. And, you know, she ended up getting a urinary tract infection that spread to her kidney. And my guess is she developed sepsis and passed away peacefully, um, which is what she would have wanted. Um, and even talking about it now, it's uncomfortable. Like there is a part of it to me that's uncomfortable. And maybe it's because I'm a pediatrician and we do everything we can to keep kids alive, and we really don't like talking about death, at least in most of the specialties in my field. But how did this experience in this story, you're doing things that are really trying to move the needle. You've started a podcast, you're out there talking about the process of aging together and the challenges of what's happening in communities of folks that are aging. What inspired you? What about the story inspired you to move the needle on a larger level?
Yeah, I think, that story was a starting point. Just being in the hospital system for so long, I had seen a lot of similar stories come
Mm,
through, right? And the gap that I consistently kept seeing was how uninformed, disinformed, misinformed, and unaware the general public is related to health and care navigation, right? And how our systems work. Our systems are extremely siloed, and everyone has, I mean, like you said, there's always a goal that the system has to meet at different levels of care. And I really wanted to find a way to educate the masses, educate the general public, build care literacy and literacy around how our health and care systems operate and work, how our insurance systems operate and work, and how that plays a role in what services you can and can't qualify for. Um, And in the community, all of this information is readily available. It's just extremely siloed, and you have to know what to look for in order to find it, right? I always joke, like, you can pay me to Google, but I know what I'm Googling, right? You can sit there and Google for something and spend a whole day and still not get exactly what you're looking for. Um, and at that time, so I started my podcast in January of 2023. And at that time, everyone had a podcast. And I was like, okay, it's accessible, it's free, I can get a lot of information out there this way. And so that's why I started with just that. The goal was just pure education. And I started with a podcast, which I then aligned with a blog that matched the podcast because I was like, okay, for people who are more visual learners and want to read information versus listening to information, let's have both options. And so that's how that started. And then from there, I started a newsletter with similar information, but a little more like different things in there. And my husband jokes that I'm building a media company and not like a direct service company. Um, and so but yeah, at its core, the goal has always been education. And so whatever format that takes, right? And through this work, I started people started reaching out, right? They're like, hey, can you help me with this? Hey, this happened with mom. I don't know what to do. Or hey, what should I do about this? And after a while, I was like, there is a real need in the community to have educational based coaching programs or coaching options or consultative roles that are not necessarily care navigators, not necessarily care managers, and not necessarily therapists, but truly just here's all the information you need to know. Here's how you can get access to it. Let me refer you to appropriate resources if depending on what they need. And then a big part of it was that proactive care planning piece that I kind of kept running into over and over again of how do we prepare these families for crisis, for hospitalization, for an emergency, for long-term care, for end of life, right? Like how do we act proactively, educate and prepare these families to do that? And so that's sort of, I mean, all of that kind of came together, and that's really the bulk of what my practice really is it's educational and it's consultative based, workshops, trainings, coaching, and then just all the educational mediums.
It's fascinating. And that story is probably symbolic. Do you know what the percentages are nationally of folks that have end of life plans? Is it
I don't
low?
know the percentage of that, but I know like only like 5% of older adults have a plan for aging in place, but 85% of them want to stay in their homes.
Hmm. Well, how is that possible? I mean, that seems like a paradox right there.
Right. And it's hard though, right? Like I talk about like my own parents and my in-laws. I mean, this is the work that I do, and to try and get them to downsize or move into a more accessible home or just, do some of the things that would make it easier for them as they're getting older. They don't want to do it, right? And
Because
so
they're comfortable in the three-story home that they live in and maybe don't see the idea that in 10 years they may not be able to walk up those stairs. Is that
or a bad
right?
fall, one bad fall.
Yeah, can we talk about that? Because falls are big in children's hospitals, but they're really big in preventing falls. And like it's a bad thing, like for a hospital to have a patient in a room and then they fall and break their hip. It feels like I mean, it's just completely out of my area, but it feels like for many older adults that are in their 70s or 80s or even 90s and they have a fall and they break their hip, and that's sort of the seminal event that leads to the end of life. Is that a fair assessment? Is that what
It is.
happens?
Yeah, so one fall doubles the risk of falling again. So preventing
Wow.
that first fall is key. And then a fall with an injury decreases their life expectancy by a significant amount of years.
Mm.
I don't remember the exact number right now, but it's a pretty significant number. as far compared to others their age who have not fallen or had an injury with a fall. Um, so yes, I mean falls are the leading cause of premature death amongst older adults.
Wow, that's
Yeah.
fascinating. And what, so there was a study that I read about recently that talks about, it's it feels like it's really evolving in the way that we think about uh, elderly and aging, uh, gracefully aging. There was a study I read that predicts how long a patient is going to live based upon how well they can get off the floor by themselves. So you put a patient on a floor, 70-year-old, 75, whatever age, and then if they can get up unassisted to some degree, and I don't know all the details of it, you probably do, it's highly predictive that they will or won't have a fall or a death event in the next 10 years. I'm probably misstating this, but can you educate us about that?
Yeah, that study has been making the rounds in the rehab space, as I'm sure you can imagine. But yeah, so that it specifically looks at someone's ability, and it doesn't have to be an older adult, even for like my age, your age, like anybody. If you can sit on the floor cross-legged and get up without assistance, that is a huge indicator for longevity, and just mobility from a longevity standpoint. And a lot of the rehab science and just medicine in general talks about how mobility is one of the key factors of longevity, right? You have to be mobile, you have to be able to get around and be active. And so, yeah, that study has made rounds. I haven't read it personally, so I can't say that I know all the details of it. But it has made its rounds and yeah, I mean, I believe it.
When you've seen so much in terms of your career at the end of life, what advice do you have for people in their 60s and 70s who are active? They're currently fine. And what are the things that folks that are aging can do to actually prolong the quality and the quantity of their life from an OT standpoint?
I'll tackle quality because quantity is subjective, I think, to a certain
Sure,
degree, right?
sure.
Comorbidities, pain, family history. There's a lot that goes into that. Quality of life in the OT space is largely correlated with social health and well-being. And what do I mean by that? Social isolation is becoming one of the leading causes of depression and anxiety among older adults. And with that,
Well,
if you are familiar with mental health in general, declining mental health impacts everything else. It impacts your physical function, your cognitive function, your ability to go out and do things. So then you start becoming less and less engaged, less and less active. And one of the primary factors that plays a role in this is your social health. And so that is taking up a lot of um, space and airtime in recent years is social wellness, and being able to involve yourselves in at least leaving your house once a day or once every other day, at least going and doing interacting with other people or going and physically doing an activity with other people, right? So it's great if you're active and you love to go on hikes and kayaking and walking and the gym and all this stuff. But if you're doing all of that by yourself and you're never interacting with somebody else, that's going to play a big role in your decline as well. And so that has been the latest on as far as like what can people really do is really maintain some semblance of social connection. Um, it's becoming increasingly difficult because you can get everything online or delivered and you never have to interact with anybody, right? Groceries,
mhm.
food, banking, doctors, like everything is available through technology now. And it's really hard to get people to leave their house and go do something.
That's really interesting. I mentioned I'm giving a talk, honored to give a talk at the University of Chicago, and hopefully we can grab some coffee. I want to learn from you about all the different successes you've had in your podcast world, and you're doing some great stuff. But
Thank
and hang out in a cool coffee shop with Pooja. But I I'm giving this talk about the past, current, and future states of my field, which is pediatric emergency medicine, and I wanted to share some data with you that you may or may not know, and that is at least in the pediatric mental health space. Um, there was a dramatic increase, a 2 to 3x increase in the number of children coming to the EDs, emergency departments, for behavioral health emergencies. So depression, suicidality, aggressive behavior, 2 to 3x after COVID hit.
you.
And it wasn't due to the virus. Almost all of us believe that it's due to two things. One is social isolation, and the second is use of social media and technology, as you inferred. So it makes total sense, and yet from my career over a few decades, this was never talked about 2 or 3 decades ago. This was really never talked about. And in the longevity world that I've kind of immersed myself in, it's been a fascinating journey. That um, that is cited as one of the five major core reasons of declining health, which is
Hmm.
social isolation, and some people use the term um, uh, finding meaningful work in the community. In other words, feeling relevant. And
Yep.
it turns out in the Japanese culture, there's no word for retirement. And are you familiar with the blue zones?
Hmm.
So there are these 5 or 6 areas of the world where there are more folks living greater than the age of 100 than anywhere else in the world.
Yeah.
And one of them is in Japan. And there was a documentary, I think it's called The Blue Zones on Netflix, very awesome documentary if you have an interest in taking a listen to it. And as part of the journey, you spend a whole episode in Japan. I think it's actually Okinawa, I may be mistaken, but I think it's Okinawa. And folks in their 80s and 90s are involved in the community.
Hmm.
They're doing community service. They're engaged with other people, um, and or still working.
Hmm.
And I, I just turned 60 this year, and so it's really interesting because when I was in my 40s, I was like, well, when I'm 60, I'm going to be retired. I'm going to retire. And then it's like, the idea of retirement's really interesting, right? Because right now I work 40-ish, 50 hours a week, and I'm engaged with lots of different things in my professional world, very stimulated. I'm of the personality type, and again, I'm an ER physician, that I think I would be very bored in retirement. So, I have this feeling like I want to stay relevant as long as I can, and also contribute to the environment. I think sometimes people have, at least in America, it's this Americana sense of, well, once I make this amount of money, I could just go off into right into the sunset. But what's interesting is that may not be what supports ultimately your quality of life if you end up waking up every morning, going shooting a couple rounds of golf alone. Maybe it's with a few people, but you just become more isolated, and I'm sure there's a correlation, correct me if I'm wrong, between isolation and mobility. You're not
Term.
isolated, you're going out into the community and
Right.
you're doing things, right?
Right. Right. We have a term in OT practice called productive aging, and that really looks at, what does productivity mean to people as they age, right? And a big part of that, we play a role in retirement preparedness and retirement planning that comes from a holistic lens of physical, mental, cognitive, social aspects, and not just the financial, right? Everyone thinks of retirement planning as a financial task, and there's really so much more to it. I know a handful of retired OTs who every time I see them, I'm like, are you sure you're retired? Because like they're still doing all this stuff, right? They're writing textbooks, they're engaging in our association activities, they're, teaching guest lectures or adjuncting because they want to still stay active. The core of occupational therapy is ensuring that people can purposefully and meaningfully engage in whatever they want to engage in. And a big part of the loss, or a big part of that social withdrawal, social isolation, is loss of purpose and loss of meaning, which impacts quality of life, right?
Why it feels like everyone should go to aging school. Why am I kidding? Like everyone should have an aging plan, right? That
Well,
includes,
yes.
a checklist of things that they should be doing to age well. Does something exist like that?
I don't know that something at large exists like that. I've created workbooks that I use with clients and that are available on my storefront if people want it. But it's more so, it's a step by step of like, here's what to look for when you're planning ahead for emergencies. Here's what you're planning ahead for long-term care. Here's what planning ahead for end of life. And, there's not holistic things that exist like that from a larger standpoint. But you're right. I mean, I think we have such a tunnel vision when it comes to planning in life, and majority of it, if not all of it, is solely related to finances. And
Mm.
right, people have financial planners, wealth advisors, you're always saving up for the future. And it's like, okay, but have you thought about anything outside of the finances? Right? Like, how are you actually
It's all
going to
about what my
live?
retire right, right, right. It's all
Yeah.
about the retirement egg and
Yeah.
what's there, and it's so interesting.
And
And it's
everyone
so much
talks
more
about like,
complex.
oh, when am I going to retire? I don't know when I'm going to retire. Oh, I'd love to retire. But it's like, okay, and then what are you going to do? Right? Because the reality is, historically, when people retired at 60, 65, they were only living maybe another 5, 10 years. Now people are retiring at 60, 65, 70, and they're living another 20, 25, 30 years. That's another career. That's another life. I mean, you have to have a plan for what you're going to do for those 20, 30 years or more, depending on when you retire.
So I was honored to be on Dr. Betsy Greenleaf. If you're on, hello. She's a very interesting woman, OBGYN, and on steroids in some way. And she had me on her podcast, and I was very honored. And she asked me a question at the end of the podcast that I think I'm going to start asking on my podcast, which is, what didn't I ask you? What didn't we talk about that you want to share?
That's a
Did
really
we
good
talk,
question.
do we cover what you wanted to cover? Or, I mean, it could be great, maybe it was perfecto, but is there an opportunity? Did I not ask you something that I should have asked you?
I think one of the things that I would want people to know is that the bulk of the work I do is to support our 53 million unpaid family caregivers of older adults in this country.
Hmm.
We have family caregivers who are across the board known in the industry as the backbone of US healthcare. And if every single family caregiver, and when I say family caregiver, I'm talking about spouses, kids, cousins, aunts, whoever steps up to support an elder in their family. Sometimes it's a friend. Um, if every single one of them woke up tomorrow and said, "I'm done, I'm not doing this," our entire elder care system would crumble because we simply do not have the resources and the manpower to meet the demands of today's elder generation. And I don't think enough people understand this, and I don't think enough people talk about it. And family caregivers just take the bulk of that work without realizing that they're taking on that work. And they're
Hmm.
usually taking it on as a second full-time job, usually balancing it between career and their own families. And there's just not enough support for them.
Yeah. Well, how do we get a hold of you? Like, what can you again talk a little bit about your podcast? Where is it played? What's the name of it? And if someone is listening, and we actually have a fair number of people who are 65 plus that are listening to both the longs and the shorts from HuMed. How do they get you as a coach? I want you as my coach. Will you be my coach?
Absolutely. I'd love to be.
Great.
Um, so the best way to find my services, the blog and the podcast are on the website, aging-together.com. It has everything there. If you just want to listen to the podcast, we're on every major platform that you could think of. We're on YouTube, Spotify, Amazon, Apple, whatever is out there, for mass distribution. Um, and it's called Aging Together Unfiltered. And what else did you ask me? Yeah, my contact form's on the website as well if you wanted to
Great.
reach out. Um,
And I,
and
I
yeah,
love the name, Aging Together. It's like such a beautiful, inviting name. And it's a brilliant, you know, brilliant marketing in some ways, but really
thank
it's a
you.
very inviting term. And yeah, I would be honored to be on your show. I don't know if you want to
Yeah,
interview a peds or ER physician that's interested in the longevity space. I've got a lot to talk about in regard to that. We've talked about that on and off on the HuMed podcast. But HuMed was started, human medicine, to really understand what's happening behind the veils of the crazy work that we do. And it's been such an incredible journey and it continues to evolve. And I'm so glad that we connected, and I'm hoping that we can connect when I'm visiting Chicago in early April. Maybe I'll release this episode the week that I'm out there, and we can talk about it.
that's great. I
Yeah,
love
maybe we'll
that.
just time it right. So it's all
That's
about
perfect.
Chicago and what's going on. So, guys, everyone listening, and again, thank you very much for being on the show and your
Absolutely.
time, and huge honor, Pooja. And everyone listening, please subscribe on YouTube, Spotify, Apple Podcasts, wherever you listen to HuMed. And I hope you all have a great rest of the day.
Thanks for listening to HeMed with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.